Okay, hello everyone. Today we have 8th lecture of online course Principles of Surgery, and today's topic is wound healing and management of the wounds. And I'm happy to introduce you to our today's speaker. Dr. Dennis Orgill is a reconstructive plastic surgeon at Brigham and Women's Hospital. He is a professor of surgery at Harvard Medical School. And Dr. Orgill specializes in complex reconstructive procedures and wound treatment. He is a medical director of Wound Care Center, and his research is focused on the development of advanced wound treatment technologies. Welcome, Dr. Orgill, and we are looking forward to hearing your presentation today.
Thank you. It's a great pleasure to be here today. I'm going to try and talk about things that are relevant to what you're doing there in Ukraine. And I know you're in the middle of a difficult conflict, so I don't claim to be an expert on military wounds, but hopefully some of what I've learned over the years you may find helpful. So I'm going to try and share my screen here now, and let's try this one. Can you guys see that? Is that good?
Yes.
Okay. So I'm going to talk about wound healing with a focus on the VAC device, because my understanding is that that's used quite a bit for some of the traumatic wounds over there, and I've done a lot of work on that. I have disclosures. I've been a consultant for KCI, which makes the wound vac, and so the objectives today is we want to understand the principles of wound healing. We want to really understand debridement, because that's so important in what you all do. Talk about reconstructive options, and then a focus on VAC and some of the science behind it. And it's called negative pressure wound therapy. And if I'm talking too fast and you can't understand me, let me know and I'll slow it down. So the principles of wound healing is we have an injury. The first thing we need to do is think about stopping the bleeding. Obviously, if the bleeding doesn't stop, then the patient dies, and then that's not so good. The second concept would be debriding to vitalize tissue. Most wounds will have some dead tissue in them, and that needs to be removed as a first step. Moist wound healing. In the U.S., there are a lot of people that hear from their parents or the people in the community that it's good to dry out wounds. We do know that wounds heal faster if they're not infected. And so keeping a wound moist is oftentimes a good idea, assuming you've done the debridement first. We'll talk about wound closure methods, and I'll give some examples, and this may be something you're interested in. And then we'll talk about sort of some of the biological principles which happen, including wound contraction, epithelialization, and then subsequent remodeling and scarring. I don't have, fortunately, I don't have any experience with wartime wounds, but I was a trauma surgeon for several years here, and I took care of a lot of civilian trauma. And then if we look at civilian trauma and wartime trauma, there are a lot of similarity, but there are a lot of differences. Typically for wartime trauma, these are high velocity missiles that cause a lot more damage, whereas civilian trauma, we tend to have low velocity injuries. You will see more blast injuries than we do, and we'll see more sharp injuries. In the middle of a war, transport's always an issue, and so that affects when you do something and what you do at the time. Here we have EMS, which is emergency medical systems. We have a well-developed transport system to get people to a trauma center or a hospital where they can get definitive treatment. Whereas in a wartime, very often people in the field we'll just need to stabilize the patient in order to get them to the next spot. So debridement, most of what we do as surgeons is surgical debridement. We use, you know, the knife and scissors and curettes and things which would be considered sharp. It's oftentimes difficult to tell, particularly after something like a blast injury, what's alive and what's dead. And oftentimes the patient needs to go back to the operating room more than once to determine what's alive and what's dead. The next concept is bacteria. And on our skin, it's loaded with bacteria, and in any wound, there's colonization. We generally do not treat with systemic antibiotics for colonization, but we'll only treat with systemic antibiotics for if there was a systemic infection. We do sometimes use topical antibiotics. They have their pros and cons, but they can be, for an infected wound, they can be pretty helpful. There are other methods of debridement, such as autolytic debridement, which we see with the body. It will do the debridement itself, create enzymes to break down tissue. Enzymatic debridement, where there are commercial enzymes which you can purchase. And then there's some high-tech things such as ultrasound and high-pressure fluids that people use for debridement. But I would say for much of what I do, and probably for much of what you do, surgical debridement is the mainstay. Now, as a plastic surgeon, we like to think about how to close a wound, and we've constructed this paradigm called the reconstructive ladder. And it's a useful thought process to go through to think we'd like to do the simplest thing that we can to close the wound and then go up. Now, there are in some cases, depending on what you have available, people will go up that ladder faster than they will in other locations. At the top of that ladder is something called free tissue transfer. For those of you that aren't plastic surgeons, that's where we take a piece of tissue from somewhere else on the body and actually transplant it and hook up an artery and a vein to keep it perfused. That usually requires a surgical microscope and a fair amount of expertise and post-operative monitoring because these things can clot off. And it does not account for technology or available resources, but it's a useful paradigm to think about what happens if we leave it alone. Will it heal? Can we pull it together and do a primary closure? Can we put a skin graft, a local flap, or whatever to close it? Now, as technology's been introduced, we have a lot of advanced technologies today, including the VAC, which I'll spend some time talking about, artificial skins, growth factors, debriding agents. We can sometimes move down the reconstructive ladder and do something that's simpler than we might have done without these technologies. And then obviously, when we're doing any of these, we need to take care of the basics, and we need good perfusion to the wound and good oxygen delivery so that we have the capacity for the wound to lay down proteins and to absorb damaged tissue. We need the proper vitamin levels such as vitamin A and C and zinc. And then in the US, we have fewer people smoking now, but smoking's really bad for wound healing. So for elective cases I will get all my patients to stop smoking before we do it. If we have patients who are on corticosteroids, those are really bad for wound healing. Sometimes we need to leave them on, but sometimes we can take them off. And pressure and excessive tension, diabetes, we see a lot of radiation wounds here, people that have had cancer that had radiation, and those all adversely affect the ability for a wound to heal. So it's important when you make a diagnosis to get a good history, to understand, do they have any of these factors that are detrimental? Have we taken care of the basics so they can heal the wound? And then think about the reconstructive ladder. And then if you have some of these technologies, sometimes that'll allow us to do something a little simpler than we might otherwise do. Now, George Winters back in the 1960s wrote a paper in Nature where he looked in domestic pigs, and he wrote a fairly definitive study, which is quoted frequently, talking about moist wound healing. And as a result of that one single study, there are thousands of wound care products available throughout the world that will help your wounds heal. And these include alginates and gels and a lot of different wound care products, and they differ. And there are not a lot of studies showing that one wound care product is better than the other. But the concept is you want something that's easy to use, that's moist, doesn't cost too much money, that you can put on the patient. Then we get to suction, and this has really revolutionized wound care, and particularly in military conflicts, because these devices are commonly used. Now, suction's been used for a long time. At the top, we have, this is a chest tube device that we use in thoracic surgery. This is a drain, which many of us use in a lot of different surgeries. And then this is a GMKA device, which is an intermittent suction device used for nasogastric tubes. So suction's been around for a while, but only maybe in the last 30 years or so has been actually applied to wounds. And this is Lou Argenta and Mike Moriquas, and they're the ones that really popularized using suction in wounds. And they published a couple of papers back in 1997. And since that, globally, this has really changed the way we manage complicated wounds. So I thought it would be useful, because I think you use these devices in Ukraine, to talk a little bit about the science behind it, and maybe we can help you better utilize these devices. If you look under a microscope at the foam, this is the black foam that goes on, you can see that it's highly porous, and that the pores are interconnected, so that when you apply suction in one part of the foam, it actually very efficiently is transmitted to another part of the foam. And so that's a very useful property of these foams. And so how does this device work? Well, we don't know everything about it, but we think that there are four principal mechanisms of how the device works. The first is it obviously drains out a lot of material. Some of this may be inflammatory, some of it may be extra fluids, and taking the extra fluid out and taking the edema out of the tissue can be quite helpful. And then it keeps the wound moist by keeping it covered, and it also kind of pulls the wound together. So when you put it in, and I typically, for a large wound where it's mobile, will put the sponge in a little smaller than the wound, and then allow it to pull the wound together by the foam. Now, if you look at where the foam interfaces with the skin, when you apply a suction, the foam pushes down and the tissue gets sucked up. And so you see here that we have these deformations. And when you deform tissue, there's a process called mechanotransduction, which allows very important things to happen at the cellular level. And so we will see increasing cell division and increased blood vessels. And you'll see that when you put on these devices. You've probably already seen that. And so this is what we think's happening at the basic level, that if you just put on an occlusive dressing, it holds it there. There's some blood vessels that form, but if you apply the vacuum device, this deforms the surface. This causes these cells to proliferate. It causes localized zone of hypoxia where the oxygen's low, and that causes new blood vessels to grow. And this is if you push down on a vac device, this is much like it might look under suction. You can see how it collapses down nicely and then springs up. Now, this is I think the first patient I used with the VAC device, this was a woman who came into the emergency room who had a dead leg and necrotizing fasciitis. And in order to save her life, they had to do a hip disarticulation. So this is her hip socket, and this is the pelvis here. This is a colostomy over here. She also needed to be diverted at the same time. And back in those days, the standard treatment for this would be to do a big flap. But she was sick. She was in the ICU, and we didn't really think we could do a flap. And the colostomy was had gone through the rectus muscle, which would have been our preferred flap to use. So we put a VAC device on, and you can see in 1 month all the bone is covered, and she's ready for a skin graft. And so with a simple skin graft, I was able to close the wound and without having to do anything too complicated. So when we see this, those of us who had been treating wounds for a long time before this device came out, we're going, wow, this is amazing. How does it work? So we did some studies in the lab to try and elucidate in a little more detail how it works. And so one of the first things we did, we used diabetic mice because they were kind of an impaired wound healing. And in the US, we have a lot of people with diabetes. And so we used a variety of things that we put on. One, we could just do the foam alone. We could do the foam plus suction, or we could just cover it, or we could do compression. And so when we looked at that, and we looked at how much strain we got on the wound bed, you can see when you compress the foam, you got some deformation at the wound bed, but when you put the suction on, you got a lot of deformation at the wound bed. And this is Giorgio Pietromaggiore and Saya Shera, who were in my lab. They actually got married, and they're now in Switzerland, not too far from where you're at. They're both plastic surgeons there, but they were the ones that did the research on this. So microscopically, you can see this is what a wound bed looks like after we apply one of these. It goes from being flat to getting these big deformations in the wound. And we believe those are important to cause the cell proliferation, because we know from basic science work that if you stretch a cell, it tends to divide and proliferate. And so then if we apply these and then we look at the wound area, it didn't change much between the two, but if you look at how thick the granulation tissue is, how thick that layer of tissue is, you can see that both the foam group and the VAC group really had a huge amount more tissue grown than the controls. And then if we do immunohistochemistry on this is a complicated graph, but if you look at the number of cells dividing and the number of blood vessels, you can see how this separates it out. And so in the VAC group, we get both cell division and blood vessel formation, whereas in the foam group, we tend to get we got more blood vessels, but they didn't. The other cells didn't divide as much. And then if you look at some of the immunohistochemistries, you can see this one is the VAC. These are all blood vessels stained, the edges of the blood vessel compared to, well, this is the control, and this is the VAC. And these are, you can see the orientation of these is much different than the control. And then we did what's called corrosion casting. So we took these wounds and we took a polymer and injected it into the heart, and it filled all the blood vessels. And then we used acid to take away all the tissue. And what you're left with is an image of the vessels. And you can see here, much like you did in the last slide, how these are normal appearing vessels that are thinned out, whereas in the control, there are these ectatic vessels that are kind of sludge filled with blood that's not moving very fast in them. And so it really changes the morphology of the blood vessels that are forming. So you might ask, does it make a difference how big the pore size is, and we know because typically we get a white foam which has very little porosity in the black foam, and the black foam tends to induce these big granulation tissue. So we did an experiment where we took foams of 3 different pore size. The one in the middle is the regular foam that we typically use, and the one on each side is a small pore size and then a very large pore size. And you can see if we look about a week later that the thicknesses of the tissue generated is related to the pore size, with the large pores, which we don't easily get today, but they provided the most. So that if you wanted to have a really good tissue response, you would do a very large pore. Now, actually, the company made a sponge where they have the regular pore size in here and then these larger pores beneath it. And I just saw this the other day at a meeting I was at. There's a hyperspectral imaging device where you can look at oxyhemoglobin and deoxyhemoglobin using light at several wavelengths. And you can see this is on an actual patient with this device with the holes in it, that where they have these very large pores, you get a huge amount of blood vessels forming, and in between you don't get as much. So it's really a confirmation of this theory of microdeformation in humans. So when don't you want to use the device? We don't like it when there's gross infection. We like to get that cleaned up first. And if there's bleeding, we're very careful with bleeding, because if you put these on and there's bleeding, the foam is very efficient at removing blood from the wounds. And actually, one of the things we'll talk about is that you shouldn't connect these things to a suction canister, because if you get bleeding, there have been a few patients around the world who've actually bled out because of this. So there's a relative contraindication if people are anticoagulated or on, if they have an increase, what we call in the U.S. INR, or decreased platelets, or if they have some sort of unstable cardiac condition. We like to put this in as one single piece to custom cut it, because we have seen several patients come back where people put in several pieces and they don't get them all out, and then the wound never heals. And then you go back and explore it and you find these old pieces of vac sponge. So we like one piece to go in and one piece to come out. And I always tell my patients to make sure in the US, we have visiting nurses do these changes most of the time to make sure the patient knows whatever goes in needs to come out the next time. And we usually change this 3 times a week. You can see the macro deformation here, how you put this on and then connect it to suction, how the wound tends to shrink down some. Now, this can be very useful in open abdomen. If you have somebody who you've explored their abdomen, you can't get it closed, you can put these sponges in. It's important not to put the black sponge directly on the bowel, because if you do that, there can be erosion into the bowel, and then you can have enteric feedings in the abdomen. So we'll put usually a plastic drape over the bowel, and then put the foam in over that, and that's able to get out a lot of the abdominal fluid and to kind of start to pull the abdominal wall together. And we can usually get our patients primarily closed if we can get the fluid out, and we rarely need to do skin grafts these days. Here you can see one of our patients where we were able to get it closed above and then or below, and then above we have the foam under suction, which hopefully over time that we can get this totally closed. So there's a commercial device called Abthera, which sort of has all these components in it, but you can obviously make your own. And one of the things is I like to try and close the skin as much as I can, because if you leave it open, it tends to retract and you lose domain over time. And we change it every 2 or 3 days. And like I say, we can usually avoid skin grafts or flaps for closure. And here's an example of, greatly swollen bowel. This can be treated for a couple of times and then the wound primarily closed. It says that it's contraindication in fistulas, but if you're careful, you can and put tubes in and carefully manage it. This can actually be pretty helpful in fistulas. And this is one of my colleague, Carl Brewing, who's a German surgeon, but he lives in the U.S. now. One of his cases that he did. And then here's another one where an open abdomen was used in conjunction with alloderm. Alloderm is a cadaver dermis, which can be placed on in an infected setting and replace the fascia. And then a vac device can be used over that. We sometimes like to bring the suction port away from the wound to avoid a pressure injury. And this is a bridging technique that you can see where we put on a protective layer over the skin, and then we'll bring the actual suction port out away from where the wound is. And you can see how this was very effective in closing this wound. So just some case studies. Here's someone who had a GYN cancer and ended up with a open wound, and these heal pretty nicely with vac therapy alone. And here's another example of how these things heal up over time. Here's a 49-year-old female who had an intracutaneous fistula that was repaired and the wound came apart. The fascia was largely together. Again, this can be treated. There's some permanent sutures in there that we would usually leave in place until it's strong enough, and then those can be removed. Here's someone who has a recurrent pilonidal disease. Somebody operated on it and did a Z-plasty closure, which broke down, and you can see just applying a vac device. Again, this is with a bridging technique. You can get these wounds to shrink up pretty quickly. Here's a woman who had a hemipelvectomy from a recurrent sarcoma, difficult closure under tension. And so here we can do an incisional vac device. We put a hydrocolloid dressing on next to the wound, cover it with a vac sponge, and then hook it to a suction source. And that really provides a very nice splint for the wound and keeps it together. Here's someone who had has a bad wound from radiation therapy. Again, had another hemipelvectomy and had a difficult operation with bleeding. And you can see they have some dead skin. So we debride it and put a vac sponge on and just wait several weeks to allow this to close down and heal. And then we see all sorts of weird things in our hospital. This woman is morbidly obese and just has this disabling lymphedema of her extremities. So then the question is what do you do for this? And so the main reason why we were forced to do this was because she kept coming into the hospital with recurrent infections. So we took all of this off and then used the skin over it, is recycled, and then put that back down as a skin graft. You can see how much we took off was, and we did kind of a Jones procedure to close this. And obviously didn't totally correct her problem, but made her a whole lot better. Here's another woman who had a kidney transplant up here and got necrotizing fasciitis. It's on immunosuppression, just a horrible thing. So in her case, we first did allograft and then skin grafts to cover this and use the VAC device. The VAC device I find is very nice over skin grafts, and can be a very nice way of holding it down. We don't use it on all our skin grafts, but we do on a lot of them. So just a couple of cautionary notes. If you put this black sponge directly on the skin, you'll get a skin reaction like that. So we usually like to put a hydrogel or a polyurethane wrap over this to avoid that. I mentioned the retained form foam before, but this is a guy who had a ischial pressure ulcer, and I went to surgery and I pulled out all of this foam out of this guy, and obviously he got better pretty quickly after I did that. I wanted to mention one other thing that you probably see quite a bit of in Ukraine, and we see here, but it's mismanaged by a lot of people. So I'm going to show you a little trick that if you don't remember anything else from this talk, if you can remember this one thing, that would be terrific. And these are degloving injuries. And so this was a young woman who got her leg caught between two bumpers of a car, and it degloved her injury. Her bones weren't broken, but she came in like this. Now, most people would try and sew this back together and just see what lived and go from then. But what we found is that if you cut the skin off and then take all the fat off, and it takes about 45 minutes to do this on this piece of skin, but you get everybody around and they're just taking every little bit of fat off, and then you use it as a skin graft. You can put it back on anatomically, just the way it was, and it won't die. And then we put a vac over the top. Because of the circumferential, we usually do this at 125 millimeters of mercury, but on this one we just did it 75 millimeters of mercury. And here she is at 1 month. We didn't have to do a skin graft on her at all. And here she is at 5 years. She's able to run on this. You can see if you look carefully at her knee here, these are the normal kind of wrinkly creases you have in the skin. And so this was sort of life-changing for her. In the U.S., our Food and Drug Administration is the regulatory body that regulates these, and that we talked about some of these, that you have to be careful that they can occur in people in the U.S. They happen most frequently with patients in long-term care facilities, and this usually occurs from massive bleeding. So we're very careful, particularly if you put one of these on a chest wound or a groin wound. We keep those patients in the hospital and don't send them home with these. So we talked about some of these before, but don't connect it to wall suction if you don't have the regular pump available, because there's no safety device on and you can bleed off. Don't put the foam in direct contact with the heart or the bowel or any other big vessels. And if you need to do it, put a non-adherent layer there, and make sure your debridement is good, and that the fistulas are, if you have fistulas, that they're isolated. So in conclusion, VAC therapy has become the standard for treating most complex wounds in the U.S. And I will hear what you say, but I think you're probably using a lot of it there. It stabilizes the abdomen, encourages healing, and preserves domain. And we oftentimes use it in conjunction with flaps and skin grafts. And just a reminder that they should be clean before you use these devices, and that you know, if it doesn't work like any other wound therapy, don't use it forever, switch to something else. So anyway, I'd like to thank you. This is where I live. These are some of the people in the lab that did the work. And I'll open it up for questions. Thank you very much.
Thank you, Dr. Orgill, for this wonderful lecture. Very important topic for Ukrainian colleagues. And we have several hands raised. Vladislav Kuzmenko, please.
Thank you, Mr. Orgill, for your wonderful lecture. I should mention that this problem very actual in Ukraine. And as for my clinical practice, I operate these patients every day with gunshot wounds, with military trauma. And I have several questions. The first of all about debridement. What ways of debridement you use? Maybe it's mechanical or you use some kinds of solutions. And the second one question, if we have a fresh wound, we perform the debridement of military wound. I mean, we removed all the necrotic tissue without any infection in the wound. So can we use in the operating room if we have adequate hemostasis? Can we use the VAC system just in operating room? Thank you.
Yeah. So for debridement, I'm probably a lot like you are. I really think surgical debridement is the best, and so that's what I use mostly. Some of the other methods I mentioned I use on occasions, but I'm a surgeon, and I do mostly debridement. And then the second question is the VAC device. We put those on very frequently in the operating room. That's the most common place where I will put on a VAC device. And for big wounds, we will often do the changes. At least the first change we'll do in the operating room. So I hope that answered your question.
Thank you, Dr. Orgill. We have several more questions, and I would kindly ask you to ask by one question because we have a limited amount of time. Thank you. Next question from Dr. Ismailov, please.
Hello, thank you for your lecture. And I have a question about wound drainage. So I see surgeons put the rubber drains in just about every case. But what are the real indications to wound drainage? Is it excessive body fat tissue or infection in the abdomen? Or should I just sew the laparotomy wound shut and that's it? No drainage.
Yeah, I think it really depends on the specific situation. There's an old adage which we say in the U.S. that you can't drain the abdomen. So I think if you have a specific area of infection that you can put a drain in for that. We prefer closed suction drains in the U.S. Rather than just a plain drain that goes out. I think that reduces the risk of contamination. But I would say that a drain can be useful in the setting of, certainly if you have an infection there, it can be very useful. And we use it also for large operations where we disrupt a lot of lymphatics because there'll be fluid. Drains are not very useful to prevent bleeding, in my experience. And they're not very helpful to just, drain the abdomen. But certainly for many other, we use drains quite a bit for infections.
Thank you, Dr. Orgill. Next question from Dr. Nozrin, please.
Good evening. Thank you for the great lecture. And I wanted to ask, do you think, is there any future for some sensing, maybe censoring some biomarkers device, like a device that could measure maybe moisture of the wound, maybe temperature or pH or some oxygenation of the wound?
Yes, and there are several research laboratories in the U.S. that are working on that, and I'm collaborating with several people that are doing that. I showed you the one device, the hyperspectral imaging device, which is basically a sophisticated camera, which is pretty good at assessing perfusion. So they've shown it for like, if you look at bowel and you can't determine if it's dead or alive, it can be useful for that. But as you point out, the oxygen, moisture, and all those things are available in a couple of devices that are in development now.
Thank you, Dr. Orgill. Next question from Dr. Lisetska.
Good evening. Thank you for a great lecture. My question is, what is the best type of dressing to protect the skin graft first days after the procedure? Is any devices or any medications for that?
Right. So I think there are two things. First, for my smaller skin grafts, I'll do a traditional bolster. So we'll put a non-adherent layer and then put some cotton or foam. I like foam, and then we'll tie sutures over that. For larger ones, I like the VAC device. So you put the skin graft on, you put the non-adherent layer, then the foam, and then cover that, and then suction it down, and it really totally immobilizes the device. So obviously that's more useful in somebody who's in the hospital. So if they're going to be in the hospital, I'll very often use the VAC. If they're going home, I'll use a bolster because the VAC is another device they have to carry around. So those are the two things I usually use.
Thank you very much. Next question from Dr. Boyarsky.
Good evening, and thank you for the great lecture. My question, what is your opinion about dressings with silver or hydrogel? What indications do you see for using them?
Yeah, unfortunately, the data for silver dressings are not very good. So, there are no definitive studies showing that the silver helps. I will use them in wounds that I'm worried about contamination or infection, but I personally don't use them very often because I don't think the data are very strong for the use of silver dressings. And I guess the exception to that would be in burns, where I do use silver dressing, but in regular wounds, I don't use silver dressings that much. But in a second degree burn, I think silver dressing can be pretty useful.
Thank you very much. And next question from Dr. Smirnova.
Good evening. Thank you very much, Dr. Orgill, for your lecture. My question is, during the treatment of a wound with a large soft tissue defect, when you decide to use VAC therapy, do you combine it with the local use of antibiotics or bacteriophages when you install this system?
So there's a VAC system called VAC and Steel, which allows you to put fluid into it. And there's a surgeon named Luc Tio in France who in France are not allowed to use antibiotics in the solution. And he got great results using just saline. So I followed his lead. And when I use the installation protocol, I'll use saline. Other people will use, some people will use dilute Dakins, or they'll use dilute betadine, or some other PHMB, these type of solutions. But I'm a believer in what Dr. Tio showed, and for those wounds I use saline, and that's worked pretty well in my hands.
Thank you very much. And next question from Dr. Moisenko.
Good evening. Thank you for your lecture. Tell me, please, what type of skin do you use for transplantation? Only allotransplants or anything else?
Well, yeah, I would say in my practice, I use primarily autologous skin grafting, but we do use allotransplantation on occasion when they don't have a good donor site, or we need more skin. So I think particularly in burns, allotransplantation is pretty good, and in large wounds it can be useful as well.
Thank you very much. Next question from Dr. Meshko.
Good evening. Thank you for presenting the great clinical cases. So my question is, how do you understand when you will decide to stop using the wax system and start covering the skin, for example, with skin grafts or just put in the sutures? So what are the criteria to stop using wax?
Yeah, so I'll look at it. The wound should be clean. As I showed you in that one case with the exposed pelvic bone, I waited until there was a very nice granulation tissue bed over that, and then that's the time to move to a skin graft. Obviously, there are other considerations like, is this patient too sick to go to the operating room? But I'd like to use the VAC as a bridge, in most cases, is a bridge to closure. So to get them so they're well granulated, they've recovered from their injury, and then the wound looks good, and then close it by either a graft or a flap.
Thank you very much. Next question from Dr. Vladislav Melnik.
Thank you for the lecture. What do you think about using of PRP or PRF therapy for treating wounds in general surgery?
Right. A lot of people are. I've got an echo here. A lot of people are using it, but the data to support it are not great. So yeah, I mean, I think if you want to use it, you can, but you have to understand that there's no conclusive published study that's done in the US. It's not covered by insurance. So if people want to use it, then patients are paying for it out of pocket. So I've studied PRP a lot in the lab, and I know a lot about it, but clinically I've rarely used it.
Okay, thank you.
Thank you, Dr. Orgill. We have another question on the chat from Dr. Boyarsky. He's asking, do you completely remove the dressing on a clean wound after 48 hours after surgery?
No, not always. And sometimes for clean cases, I'll leave the dressing on for a week, depending on what the dressing is. So I think it depends on your risk for infection. But if the risk for infection is low and there's not a lot of drainage, actually, I think leaving it on for several days has some advantages, because then when you take it off, the skin's like totally healed underneath. There's no drainage. And also keeping the dressing on, we often use these semi-occlusive polyurethane dressings. It helps splint the wound, which I think helps it heal and probably reduces the scar somewhat. So I think, yeah, you can take it off in 48 hours, but if it's clean and low risk of infection, leaving it on longer sometimes can be good.
Thank you very much, Dr. Orgill. I wanted to ask you also one question. Speaking with several plastic surgeons in Ukraine, I started to hear that due to the lack of wound vacs in Ukraine and in Europe, due to the war, some plastic surgeons forced to use improvised devices like aquarium air pumps, just converting them into wound wax. And what are your thoughts on these improvised technologies?
Well, I mean, you have to do what you have to do. I would just be careful if you hook it up to suction that you don't have a huge canister and you have some safety device so that the patient won't bleed out. That's the only thing to think about. So if you have a small pump, then that's fine. But in our hospital, we have suction systems that go like down to the basement for this huge pump, and I wouldn't hook it up to that. But if you had a small mechanical pump, or you had a vac pump from a previous patient and you wanted to improvise and make it out of, some other materials you have in the OR, I mean, I think that's probably okay, but just be careful you don't have some big canister so that the patient bleeds out.
Got it. Thank you. One more question in the chat. Is there a difference between regular foam sponge and silver sponge?
Just the silver, the pore size is about the same, but the silver obviously has silver in it. And I've used a silver sponge some, and I suppose if you have an infected wound, it's probably a reasonable thing to do, but there are not great data to support the need for silver.
Understood. Thank you. And last few questions from Dr. Nozdrin.
We know that a WAC therapy could take a few weeks or even months to heal, and after that you need to do the skin graft. And unlike the flaps, the patient could heal like in lesser time. How do you know what technique to use, flap or WAC and then skin graft?
Right. So I think that depends on your experience. If you're a plastic surgeon and comfortable using flaps, then as you point out, doing that earlier will get the wound closed faster and will avoid problems. But if you don't know how to use a flap or you don't know how to do a skin graft well, then you may be stuck waiting a little longer. But I think it depends on your experience. Obviously, some advantage to closing the wound sooner rather than later.
Thank you, Dr. Orgill. One more question from Dr. Ismailov.
My another question is, how do you care about skin around the stoma? Sometimes we have patients which they go home and they come back a few days later with a huge wound around the stoma. It is infected. It can have feces or intestinal contents in it. So how do I prevent it? Maybe some recommendations on that.
Yeah. So I think the first thing is to be very careful when you make the stoma, to make that properly so that you have precise healing between the intestine and the skin. The second thing is to make sure your stoma dressing is perfect. So when you cut out the O around it, that is the exact perfect size. So I think prevention's the best thing. Once you get a wound, it's really hard. It's hard to heal. And, you use your normal wound healing things. Sometimes if the skin gets red, we'll do things like topical steroids. Sometimes we can put on like a zinc-based paste to prevent wound breakdown. But I think avoid wounds at all costs on stomas is the best thing to do, because once you get a wound there, it's a difficult problem.
Thank you. And the last question from Dr. Lisecka.
Dr. Orgill, do you have any experience with WAC therapy with frozen abdomen? Maybe you have any advices, or when is the time to stop the WAC therapy, if you know?
Describe to me what you mean by frozen abdomen.
When you don't close the abdomen for a long time, and this has biofilm during.
Okay, yeah. So I think the best way for the open abdomen is to take them back to the operating room every 2 or 3 days and to try and advance the tissue together, and we can get most of them closed. The ones that we can't close, then we'll put a skin graft on. That's what we usually do, but it's rare in our hospital. A couple of things. One is we've cut down on the amount of fluid we give during the operation, and so that's helped a lot. And then the second, by taking them back to the operating room every 2 or 3 days and to try and partially close it together, it's rare that we have to skin graft, but maybe every 2 or 3 years in our hospital, somebody will need a skin graft, but sometimes you need to do it.
Thank you very much, Dr. Orgill, for your lecture and answering all these questions. We really enjoyed it. So thank you very much.
Thank you for the opportunity. And I wish everybody over in Ukraine, I hope this conflict ends soon and that things will be better for you in the coming months.
Thank you very much.
Okay, bye-bye.